Good morning, good afternoon, and good evening, and welcome to this webinar on falls prevention services in FLS. My name is Eric Prédé-Champagne. I'm the Capture the Fracture Coordinator at the International Osteoporosis Foundation, and I will be the moderator for today's session. Before introducing our speaker, I would like to inform you that all participants are automatically muted for the duration of the webinar. I'd also like to encourage you to ask questions during the webinar by typing them into the question box of the control panel. I'll voice all the questions to our speaker during the question and answer session planned at the end. With this introduction completed, I will now introduce today's expert speaker, Assistant Professor Daniel Pinto. Daniel Pinto is Assistant Professor of Physical Therapy at Marquette University, Milwaukee in the United States. He's a scientific collaborator at the University of Liège WHO Collaborating Center for Public Health Aspects of Musculoskeletal Health and Aging in Belgium. He's published over 40 peer-reviewed papers, and he was the winner of the SKO-IOF Fellowship Award in 2015, and in 2020 he received the SKO-IOF Pierre Meunier Young Investigator Award. He's the co-chair of the IOF Rehabilitation Working Group and part of the steering committee of the Osteoarthritis Action Alliance. It's with pleasure that I now leave the floor to today's speaker, Assistant Professor Daniel Pinto, for the main presentation.
Thank you very much for that kind introduction. And bear with me while I get the slides up. So today, as Eric mentioned, again, we're going to talk about fall prevention services overall in the context of the FLS. So our objectives today are to talk about risk factors and really just sort of level set on the consequences of falls in older adults, and both in terms of morbidity, mortality, and economic costs, and to understand some key components of falls prevention services and how the FLS integrates with these falls prevention services and facilitates them. So what is a fall? The World Health Organization defines a fall as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. Falls, trips, and slips can occur on one level or from a height. We know that falls often will result in a fracture if someone has some underlying frailty or bone disorders such as osteoporosis. And so we know that as we age, we have more falls and we have more fractures as a result of falls. So you can see annual fall rates in people who are greater than 65 years old are just about 1 in 3. So that's our base rate that we should be thinking about. Every 65-year-old who comes into our clinic, we should be thinking at a base rate of 30% of individuals in that age group will have a fall within the last year. And when someone is 80 or older, we're now at a base rate of 1 in 2. So just thinking about those questions, asking about falls, if we have less than 30% of people saying that they have a fall in our 65-year-old population, we'll talk about ways in which to ask with more specificity. We do know that 5% of falls will result in fracture and hospitalization. And so as we just think about our aging population, and just the vast numbers of those who are falling, even though 5% seems like a small number, it really does result into a lot of morbidity, mortality, and cost. Again, when we're thinking about your lifetime risk of a fracture, 1 in 2 women will have a fragility fracture over their lifetime, and 1 in 5 men over the age of 50 years old. One of the things that's important, and I think when we get into falls prevention services, is this idea that falls happen in context, right? They're not isolated events. And so what are the risk factors with falls? Clearly, age is a risk factor. A history of a fall is a risk factor. But then you have all these other risk factors that are modifiable. Muscle weakness, poor balance, medication, sort of polypharmacy. visual impairments, and comorbid conditions. And, perhaps comorbid conditions aren't necessarily modifiable, not always, but certainly there is a potential for overlap in terms of the treatment and its implications for fall services. When we think about fracture risk increasing, certainly that happens in the presence of bone mineral density. We know that a previous fracture increases the risk of a future fracture, especially within the next 2 years, and it's a substantial increase in risk. Female sex, smoking, high alcohol consumption, and low BMI all increase fracture risks in the context of falls. So when a fracture does occur, there's some big consequences. We know that certainly bone mineral density is lost, muscle mass is lost in the presence of a fracture, pain also increases. We also have significant increases in disability and loss of independence. About 40% of individuals who fracture their hip will be institutionalized or unable to walk within the year. And 60% of those, even who do walk, will require some form of assistance. We know that approximately 25% of individuals who are older adults who have a fragility fracture, especially in the hip, will die within the year. And so there are significant losses of independence, significant morbidity and mortality associated with a fragility fracture. And this translates into hundreds of billions of dollars in costs in our health systems across the world. And so that's why there's a really big focus. The morbidity, mortality, the economic cost has really heightened the focus on trying to address and manage fractures over time and falls. And so when we think about fall prevention services, it's really about, it's a whole system approach, whole system thinking, meaning when someone is well, they should be doing activities to optimize their mobility and decrease their fracture risk. And as they have an injury, an ailment, as they increase risk for one reason or another, maybe through comorbidities, polypharmacy, we then try to activate a falls prevention program. And when indeed there is a fracture, the Fracture Liaison Service being best practice to prevent someone from slipping through the cracks and that spiraling into future fractures. And so sort of catching them and bringing them back into these fall prevention services through a staged approach. So the systems approach to fragility fracture care and prevention has really been developing over the years and has a number of iterations. This is from the New Zealand Hip Fracture Registry. And one of the nice things about this is just talking about sort of the lifestyle approach with this. From the top down is how we as a health system might be able to most cost effectively engage and minimize future fractures. From the bottom up is more a societal approach to being forward thinking about minimizing fragility fractures over the lifetime. And so from the bottom up, you're starting off with children with healthy bones aged up to 18 years. And we're really thinking about how do we optimize peak bone mass through physical activity guidelines, through nutrition. And we continue to move up and we look at the adults with healthy bones, age 19 to 64 years. Again, healthy guidelines, optimizing 150 moderate to vigorous physical activity minutes as a minimum, right? 2 days of strength training per muscle group per week as a minimum. in terms of optimizing healthy bones and joints. As we move up into the older age range, we're looking at adults with healthy bones. Age 65 and older, we still have the minimum requirement of 150 moderate to vigorous physical activity minutes per week and 2 strength training days per week per muscle group. We also add in balance exercises as a way of decreasing falls. So now we're looking at events where fractures come into play, and you'll see over here, this is really where an FLS is initiated for secondary fracture prevention. So one of the things that is necessary when in the presence of fractures is that we need to identify them, right? So having case finding for hip fracture patients, which tends to be the easiest, so it's the first place to start, and has highest cost effectiveness, and then case finding for non-hip fragility fractures, and then moving into Fracture Liaison Services to shepherd our patients into the right services. Another way to, I know this is a busy slide, so we're going to unpack this section by section. But this is the falls prevention risk stratification algorithm published by Montero Odasso and colleagues just this year. And one of the things I really like about this is this idea of, on the left, on my screen, top left, opportunistic case finding. So this is starting from the context of someone who is in the community, is accessing health care visits, is seeing perhaps a multitude of health providers, and all health providers for someone who's over the age of 65, some would argue 50 and older, should be asking about falls over the past 12 months. But let's put this in the context of that 65-year-old and older, because we know that 30% of them will have had a fall in the last year. So if we aren't getting that level of individuals within our clinical practices that are reporting to us that they have indeed had at least one fall over the year, we can ask 3 questions to add a little bit more specificity. We can ask, 1, have you fallen in the past year? 2, do you feel unsteady when standing or walking? Or number 3, are you worried about falling? And having a yes to any of those 3 questions would also facilitate in this algorithm an assessment of several factors. Has there been an injury? Is there a fall, right, in the last year greater than 2 or greater? Is there frailty? Does the patient have frailty? Has the patient had any of these situations where they were either lying on the floor and able to get up or had a loss of consciousness? And then we can move into different directions of this algorithm. And we'll take a step through this algorithm, really thinking about the low fall risk patient. And so this will be a little bit repetitive for what we've already started on. So we'll move through this somewhat quickly. So opportunistic case finding, somebody comes into your clinic, you ask your 3 questions, and they say, no, they're not concerned. They haven't had a fall. We move on here. They're a low risk patient in terms of falls risk. And so then we educate them on falls prevention in general, and we advise physical activity exercises. And here indeed are the recommendations that I've already said for our older than 65-year-old population when it comes to physical activity. Other periodic screening that we should be doing in terms of falls prevention is identification of whether or not there are any vision impairments. If somebody has glasses, if they use glasses or some form of eyewear, just kind of best practices of not getting up before they have their glasses on, making sure they have their glasses wiped clean and accessible to them, going through things like screening of hearing, assessment of foot care. As we know that our populations begin to have more and more comorbidities, diabetes is quite common. in older adults. And so we know that foot care and proper management is important in our diabetic populations, and so they are comorbid with our osteoporotic and falls population. And so one best practice with foot care is wearing a rigid-soled foot, rigid-soled shoe around the house, not walking barefooted, not walking with slippery kind of socks or something like that. Medication review and modification, particularly if our patient is comorbid with perhaps a cardiovascular issue or with depression. We know that certain medications can increase dizziness. And so just having an assessment about medications and their impacts on the patient. And home safety assessment and falls self-assessment. So there are many falls self-assessment tools that are out there. I'll show you another one in the next slide. And a home safety assessment, again, are readily available, but common things to look for would be sort of tripping hazards like loose rugs in the home, poor lighting, and no sort of guardrails on stairs and things like that. And there are really robust lists to home safety assessments that really we should be all familiar with and starting to integrate just in terms of community safety as we're working with our older adults. So a self-assessment checklist would be, I'm not going to read all of these through. This is from the CDC in the States and the STEADY initiative. But if 4 or more answered as a yes, they would prompt the individual to contact their GP as they might be at a risk for falling. And so these are, this is a very brief screen. There are certainly more robust and rigorous screens that are out there that different countries are employing. New Zealand and Australia have about a 4-page online screener that then gives an assessment on falls risk to a member of their population. But these self-assessment tools are really helpful for people to just become more aware and get to know their bone. So as we're moving on to more of an intermediate falls risk, again, thinking from the community perspective, we can look at someone who says yes to any of these 3 questions, or is in fact in the presence of a healthcare individual with a fall or a fall-related injury. And so you're going to make your same assessment with respect to fall severity. Have they had an injury greater than 2 falls per year, frail, lying on the floor? Is their gait or balance impaired? And so I will review these 2 assessment tools to assess gait and balance impairment. And if that's a yes, then they would be identified as intermediate risk. And we'll go through tailored exercise programs, and we'll talk about those programs after a brief review of the gait speed assessments or the gait assessments. So the first is gait speed. And there are multiple protocols in which to assess gait speed, but a acceptable one is doing something like this, having someone start in an acceleration zone, so get up to speed. You then click your timer at the beginning of a 4-meter testing zone. At the end of the 4-meter testing zone, you click your timer again, so you get your number of seconds in which the person was able to walk over 4 meters, and then you have your deceleration zone for a meter. And then you look at total distance over time. And so in this example, if it took this person 5 seconds to walk 4 meters, you would have 4 meters over 5 seconds and at 0.8 meters per second. And so we know that 0.8 meters per second or less is a risk for falls. And so someone would be identified as intermediate risk. An alternative strategy that's recommended is to use the timed up and go test, where we'd have our patient seated in a chair, and we would ask them to get up, walk to a cone 3 meters away, turn around, walk back, and take a seat. And they even specify the instructions, and you, on the word go, you begin the timing, and then after the patient's seated is when you stop the timing and you record the time. Greater than 15 seconds to do this activity increases the risk for falls. And so again, someone would be sort of slotted into this intermediate risk group. So now we're going to talk about briefly some exercise programs that work. And I think what we found over the years is that exercise programs work very well at reducing falls. And so these are exercise programs that are community-based. And then we'll talk about the FLS being as a means to connect with some of these different types of exercise programs. So there's high certainty evidence that well-designed exercise programs reduce the rate of falls by 23% among community dwelling older people. One of the things that's really, I think, really encouraging in terms of the ability to scale these programs is that there's no difference in the rate of falls with individually versus group supervised programs. So with someone who is at perhaps a low to moderate risk for falls, there's not a particular need for an individually supervised program. Group programs work well. There are no differences when delivered by a health professional versus a trained exercise leader. So someone with appropriate training does not have to be a licensed physio. They can be, doesn't have to be, right? So thinking about scalability, we can train a lot of exercise leaders who don't have full training as healthcare professionals, and they can carry out more of these programs. Another nice thing is that you don't need to stratify necessarily based on falls risk at inclusion for these programs. So someone at a low falls risk versus intermediate falls risk would both have equal benefit from a exercise program. And that age doesn't differentiate on the rate of falls that have been improved with these programs. So the different programs and the different rate on fall reduction by exercise program I have listed here. So we have 25% rate of fall reduction in a balance and functional exercise program, and that's with high certainty. So if you want to move with most confidence in a exercise program that you may want to pair up with your FLS, it would be one that focuses on balance and functional exercise as a delivery mode. With moderate certainty, Tai Chi can reduce the rate of falls by 23%. Again, with moderate certainty, when you combine the balance and functional exercises with formal resistance training, lifting weights, you can have a 28% rate of fall reduction, but you have a decrease in certainty relative to balance and functional exercises alone. And when we started, when this is Sherrington et al., I used the royal we there. I was not part of this author team, so forgive me for that. When Sherrington et al. Did some subgroup analyses and looked at dosage alongside the interventions, they found that they were able to find a 42% rate of fall reduction when the exercise was dosed at more than 3 hours per week. So that initial guideline, which was the government guideline for physical activity for older adults, not in the presence of any comorbidities, said there should be at least 2 hours or 2 days of strength training. We can think about this as being, it could be 2 days, but 3 hours per week. This would optimize outcomes. So when we look at strength training and balance training, we can get into a little bit more detail about parameters that have been sort of best practice. In the format of the programs, authors found that if it was at least 50 hours of balance training and progressive strength training delivered at a frequency of no less than 2 hours per week, that met a minimum threshold in other meta-analyses. And I think I just want to unpack a little bit this idea of progressive strength training and this idea that programs should include a challenge to balance as sort of best practice. So what is progressive strength training? We know that there's a minimum criteria that's needed, a minimum stimulus that's needed to build strength. And so when we're conducting strength training exercises, whether they be doing a functional movement that creates challenge to multiple muscle groups, or using perhaps a single muscle group with an external weight like a dumbbell, we know that exercises must reach approximately 60% of a 1 repetition maximum in order to build strength over time. That is sort of the minimum sort of stimulus and load. We do know that our bodies are incredible in that they respond to stimulus and load. And so what is that becomes easier over time. And so we need to continually increase load to match and appropriately strain our muscle groups. So that's the progressive nature, right? As we may start off low and slow, as is best guidance with older adults, with any type of exercise program. But as we accommodate and things become easier, we need to then add load, add resistance. So a good way to assess whether or not a patient is doing enough to increase strength would be based on number of repetitions with good form. So if our patient is able to do 15 repetitions with good technique, using whatever load it is, their own body weight or an external load, then the load may actually be too low in order to meet that 60% of 1 repetition maximum. So if you're envisioning that there might be an exercise program where you have someone just doing an arm repetition and they're doing 25 repetitions, going up to 30 repetitions, and the form is good, and they're not identifying fatigue in the muscle group that's being targeted, the load is too low for the patient. And so that might be a nice way to just assess an exercise program that's being done as a referring provider. Other best practice, 1 to 3 sets of 6 to 12 repetitions in this range of repetition max from 50 to 85%. Is a good place to start. And the reason why we're a little bit lower on the repetition max is because you want to begin with a tolerable load with new exercisers. So start low, go slow. You could begin with a tolerable load at 1 set, and then try to really quickly move up to a minimum of 60% of a repetition max. And to do this 2 to 3 times per week per muscle group. When we're looking at functional or balance training, we're really thinking about functional training as being multi-joint, complex, dynamic movements. So thinking about your lunges, your squats. The really nice thing about this is that it can have positive effects on reducing falls and positive effects on activities of daily living, because oftentimes they replicate activities of daily living. Lifting up multiple joints in order to lift a leg up in space, that you can replicate entering into a shower, right? Or entering into a bathtub, or squatting down to pick an object from the ground. When we're looking at balance training and we are looking to take it to the point of challenge, we do want to move beyond, say, a single leg stance. Single leg stance is a really good exercise if it's meeting people at their point of challenge. if it's no longer meeting a person at their point of challenge, then we want to think about what we can do to increase that challenge. So in general, with balance training, we want to think about increasing challenge by reducing base of support. So going from double limb support to single limb support. We want to remove upper limb support if we are using upper limb support to stay stable. We want to think about moving the center of gravity. So, how can we begin to maybe add in a bit of a shift in center of gravity, weight shift, as a really basic first step, either moving forward, back with double limb support. You can then move to a tandem, sort of like step stance, and then also start to begin bringing in shifts of gravity. And then you can also add in dynamic limb movement so that as you're moving arms around, it actually creates a perturbation or a push on the trunk as a whole. And that can be ways of increasing balance training and resistance. And as we're thinking about perhaps a higher risk individual, this may be where one-on-one training is needed with a physio, right? With the physiotherapist, where you're now working on movements that are really challenging balance, and we have someone who has relatively low capacity, and so that's where we might bring that in. So there are a lot of really good resources out there in terms of exercise programs that are available. I've taken this content from the IOF's website and their pamphlet on reduce your risk of falls and fractures. And there are free online exercise guides. It's the Strong, Steady, and Straight from the Royal Osteoporosis Society. There's Too Fit to Fracture from Osteoporosis Canada. In the States, the National Council on Aging has an article on evidence-based falls prevention programs that are advocated by the federal government. So there are a lot of options that are out there that have met sort of basic screens of being evidence-based and that are accessible for older adults in the community. We're now going to move on to our higher risk patients. And so these are individuals who are more likely to be met within the FLS. So this person, if they've had a fall in the last 12 months and they haven't had an injury, you technically can still be high risk. But in the context of an FLS, clearly they will have had a fracture. And so these similar features of this algorithm will come into play, whether or not someone in this algorithm is high risk without a fracture, or in the instance of the Fracture Liaison Service, they have had a fracture. And so in the Capture the Fracture program, which is the IOF's global flagship program, we've really looked to facilitate the implementation of Fracture Liaison Services in order to, one, identify fractures that are caused by osteoporosis, treat appropriately, which includes falls prevention programming. So we're going to step ahead to the best practice framework on what falls prevention services look like from the Capture the Fracture perspective. And so one of the things about the Capture the Fracture best practice framework is to identify if in fact falls prevention services exist within the FLS and are being referred to. So a minimum practice is to identify, assess falls risk, and to make a referral for a falls risk assessment and a referral to falls prevention services. And we can look at different levels of meeting this best practice framework guidance. Level 1 is that 50% of patients who are presenting with fractures who are perceived to be at risk for further falls are evaluated for whether falls prevention services are needed. Level 2 is 70% of patients presenting are evaluated. And level 3 is that 90% of patients who are presented with fractures are evaluated for falls prevention services, and that they deliver evidence-based interventions. The evidence-based interventions are indeed the ones that, the components that we've talked about. So there are different questionnaires that can be used in terms of risk assessment, and the Falls Prevention Service Best Practice Framework questionnaire would have different questions that are being asked within the FLS to make sure that these standards are indeed being met. One of the things that the FLS is recently and that the IOF has published on is looking at key performance criteria for individuals. So looking at the number of patients with falls assessment or screen performed, recommended or referred, or are already under a falls service versus the total number of patients identified. That's for falls risk assessment. And then the same is for strength and balance. And one of the guideline criteria is that this would be strength and balance performance would be commenced within 16 weeks of any fracture. This is often quite common to be done in hip fracture, as a hip fracture rehabilitation includes strength and balance, and it's less commonly done in non-hip fractures. And so this is where I think the area for improvement for fracture liaison services exists based on recent reviews of the literature and demonstrations of performance of FLS. Oftentimes the referral is made, but the referral is not taken up by patients who have had a fracture and have been identified in the FLS. Common components of a falls risk assessment would be to assess mobility, to assess sensory function, again, thinking in addition to vision and hearing, also thinking about vestibular function and the assessment of dizziness, looking at person's ability to perform ADLs, assessing cognition, as well as delirium post surgery and fracture, assessing autonomic function, orthostatic hypotension and urinary function, assessing comorbidities that may increase risk of falls. So we know that diabetes, osteoarthritis, for example, are very common in our osteoporotic patients who fracture. And so when integrating an exercise program, needing to be considerate, for instance, of an arthritic joint that may be painful, as well as the post-fracture pain. We briefly discussed medication review, and that medications could have side effects of dizziness and increasing falls risk. And so best practice is to perform a medication review and have a dialogue with the primary care physician or geriatrician that looks to change out medications based on effectiveness for its primary prescription, as well as decreasing side effects. Assessment of nutrition, malnutrition, and frailty, as well as assessment of home and community environment in terms of adding falls risk. So this is the sort of multifactorial falls risk assessment in a nutshell, and it goes hand in hand with exercise programs for the falls risk assessment and falls prevention. An example of this from the Australia and New Zealand hip fracture care clinical standard is how this is worked out in a fracture liaison service in Australia and New Zealand. So they have operationalized that within hip fracture care, that surgery is occurring within 48 hours. That's not necessarily related to falls prevention, but it has implications for future morbidity and mortality. That mobilization without restrictions on weight bearing the day after surgery, and at least once a day afterward. And then this idea of before a patient leaves the hospital, that they would have a falls and bone health assessment, and that a management plan that would be created, individualized to the patient, and that management plan would be in coordination with rehabilitation services, and it would be in coordination with the general practitioner, and that everyone gets a report of this management plan within 48 hours of discharge. So this is a really robust sort of standard that is operationalizing these other pieces of an individualized care plan, rehabilitation services, connecting with the general practitioner, and moving from there. So I wanted to allow some time for different questions that we might be able to have in terms of the falls prevention services and integration within the FLS overall. So I want to leave that here if possible, Eric, and then use the remainder of the time for a dialogue.
Perfect. Yes, that's perfect. Thank you very much, Professor Pinto, for this excellent presentation. Thank you for introducing us to the falls risk assessment stratification, as well as how to integrate that into FLS. So as Professor Pinto mentioned, this is something that is really important for FLS in order to make sure that we're reducing the risk of future falls in all the patients that are identified and evaluated through the FLS. So I'd like to invite everybody who's joining us today to take a moment and write down any questions that they have. Reminder, there's the Q&A box at the on the control panel of your Zoom client. So let me begin with a question here. This is related to what you were mentioning in terms of practical tips for the patients to reduce falls risk. So we have a question asking, would you recommend enclosed footwear, so really closed footwear, to reduce falls?
Yes, I would. I mean, I would recommend a footwear that would, protect the foot all around, but also just have a nice non-slip bottom. But that's hard. Yeah.
Yeah. Great. Another question I'd like to ask is, so how can you judge the quality of a falls prevention program overall? Let's say you've got multiple options in front of you. How do you know if a falls prevention program is of good quality and is going to have good quality evidence?
Well, the nice thing is that a lot of that assessment is being done by national bodies, right? Governing bodies. So the CDC in the STEADY program has an entire list of programs that have met a standard of being high quality, from usually reduction in falls rates as assessed in clinical trials. I think, one of the things is that we need to have an assessment of feasibility. How easy is it going to be for us to maybe support the integration of something like that within the context of the FLS? And all this happens in partnership with your patient. And so, I think part of perhaps an explanation of this disconnect between, a 70% referral rate to risk assessment and a 6% adherence rate or uptake of a falls prevention is that a lot of times we prescribe. And I think best practice is that it really becomes a partnership decision, because we know that much of what we do in life is preference-based. And so, yes, somebody has a fracture, they're likely going to have a surgery, they're going to go into rehab, but then beyond that, it's really a preference-based decision, right? In terms of, are they going to engage in a program? So the good news is that there are a lot of programs that do really good work, right? So if your patient has an interest in Tai Chi, sort of exploring a novel movement, a Tai Chi program is going to do great work of preventing future falls, probably because it has, really complex movements that it uses, right? So thinking about those functional movements, thinking about body control, balance, if that's where your patient is excited to move, I would partner with them and move forward there. If your patient's not interested in that, but maybe a little bit more interested in more of a balance program, strength training program, I would move them in that direction and partner with them to go there. When you're making a judgment on those, I think we can look to the parameters that we've discussed earlier today, and just have an assessment. We can ask our patients, are your muscles feeling tired on a daily basis in which you're in the program? If they're doing a program and it includes a squatting program, a lunge, that includes lower body strengthening, and they're not feeling delayed on what's known as delayed onset muscle soreness, or muscle soreness, then they're probably not doing enough, right? Actually, I'll remove the probably. They're not doing enough. So I have had multiple patients tell me that either my physiotherapy program was doing something wrong, or because they were feeling pain in a new area. And they would explain it by saying, hey, instead of having the pain in my back where I had my fracture, I'm feeling this pain in my legs, and I'm concerned that the pain is spreading. And then I've had to have a conversation about the difference between muscle soreness, which is a sign of growth when we're doing it in the right way in a controlled fashion, and the pain associated with a fracture. So those are things that I think, as we get more nuanced about, we'll be more likely to achieve even better outcomes, because the programs that were more adherent to strengthening protocols and principles from exercise physiology were more likely to be effective.
Okay, great. Very insightful answer. Also for the expectations on the part of the patient as well, describing pain and understanding the pain of properly done movements. So the next question I have here is asking about muscle groups in particular. What muscle groups should be included in functional resistance exercises?
I tend to like to, work on the entire body. So, but we're thinking, let's think of it in the context of a lower extremity injury. We're definitely going to want to include exercises for muscle groups that are for the lower extremity, right? And so if we're looking at functional resistance, we would be thinking about things like, squatting exercises, lunging exercises that replicate really often what we do in the day. If we have to bend down to get something, we're going to want to do it with good form. And so I usually tell my patients that they're always doing a trunk exercise, because as they move, they will be engaging what we call the core, right? The abdominal muscles, which also gets a co-contraction of their back muscles. And then when we do that and move through a lunge activity, that really gets a full body exercise going. One of the things that's important as we're having this conversation and we're training with our patients is that we are avoiding, breath holding, right? The Valsalva maneuver or anything like that. So an important thing that I like to tell my patients is that when they are contracting their muscles and when they're feeling them activating, they want to be breathing out, right? So with a push movement, you can breathe out with the push, and then you can breathe back in with, say, if that was like a chest press, as you're bringing it back in a conventional chest press.
Okay. Excellent. Thank you for the response. So here I have another question. It's similar in scope, but here we're asking, do you recommend customized exercises for areas that have decreased BMD based on DEXA scanning? So, for example, in the wrist or the spine or hip, in addition to kind of balance training or anything like that. So if you have low BMD in the wrist, do you target the forearm, for example?
Well, we know that that's best practice, right? So being specific with your exercise to the area of low BMD is indeed best practice. So for instance, if you had low BMD at your wrist and you did a jumping program, if we were thinking not, post-fracture or far post-fracture, where we can sort of do something like that at the lower extremity, you would not expect to find a change at the wrist if you were doing a program of bone loading at the legs and in the back, right? So indeed, at the area that you have your bone mineral loss is where you would want to focus your exercise. I think that's slightly different than falls prevention. I will say that just as a note, I understood that as how would you sort of optimize bone loading, which we didn't really, maybe talk about today very much. Those are, kind of impact type of exercises, bone loading exercises. Those do need to be targeted for optimizing and increasing BMD. Slightly different is, I think, the ways in which we need to expose our body to challenges to prepare for falls and to prevent falls. And actually, so I use the word prepare. I just want to say one thing right there, Eric. One of the things that I think is coming out more in the literature is trying to get a bit of a change in mindset around falls in general. We know about people like with falls self-efficacy, and they, some people are really, we know that if people are very worried about a fall, they're less likely to move, and they will increase their risk of falls. As the falls self-efficacy literature is increasing, they're actually increasing sort of, they want to better understand the entire fall sequence. So pre-fall, sort of, you start to lose your balance, you're falling. What's your confidence that as you're falling, you can minimize your impact? There are techniques we know from martial arts, people learn how to fall, right? That's now being kind of pulled into the older adult literature. And should we be training people on what to do in the event of a fall? The actual, there's time that you can do something during that fall, right? Can you kind of try to relax your body, protect your head, tuck yourself in, right? And have, in fact, a lower impact than not doing that otherwise. And then post fall, what is your confidence in being able to get back up? So that's where the falls self-efficacy literature is going. And the literature with older adults in terms of, safe falling to this, as safe as you can be, and then confidence in being able to get back up. And so that some people are putting a label as falls preparation, right, versus falls prevention, and that there's sort of like a two ways to look at it.
Very insightful. Yeah, falls prevention and falls preparation. So to all the way until the actual fall occurs. Very, very insightful. So with that said, I think this brings us to the end of the question and answer period. I'll just make some closing remarks, and then we'll end the today's webinar. So on behalf of the International Osteoporosis Foundation, I'd like to thank everybody for their participation in this webinar. I hope you enjoyed the session. You'll be prompted to complete a brief survey immediately after the webinar, and we'd really appreciate your input and comments as we continuously try to deliver webinars that meet your needs. If you have any questions or comments, please don't hesitate to contact us by email at capturethefracture@osteoporosis.foundation. You can find that in the chat box as well. And I would like to sincerely thank one more time Professor Daniel Pinto for your outstanding presentation and the insightful discussion.
Thank you.
With this said, I wish everybody a very pleasant morning, afternoon, and evening ahead. And I look forward to seeing you at our next webinar. Take care, everybody.